بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. أعزائي أبنائي إخواني الطلبة، يتجدد بنا اللقاء في محاضرة جديدة من سلسلة محاضرات Ophthalmology Made Easy. As we have spoken before in the first lecture of keratoconus about the basic principles and the definition and the pathogenesis of keratoconus and the classifications. Now in the second lecture regarding the comprehensive update about the keratoconus, we will speak about the treatment modalities, the recent advance of modern keratoconus management. We have spoken in the previous lecture regarding the cross-linking, and we understood the indication and the importance and the principles of cross-linking and all the details regarding the cross-linking. Now in this lecture we will speak about the second modality of the modern management of keratoconus, which is the use of intracorneal ring segments. We will speak about all the details about this aspect, and I hope that you will enjoy this lecture. And let's dive deeply and go and see what's inside. Now to quickly go through the modern management of keratoconus, we should understand this hierarchy of the management of keratoconus, that we have to go through three stages in the management. The first stage is to improve the stability of the cornea, and the second stage is to improve the shape or the topography of the cornea, and finally we will end up with improvement of the visual function of the patients. Now we should understand these steps so that we can understand the effect or the role of the intracorneal ring segments in the management of keratoconus, and realize the importance of the intracorneal rings in the maintaining the shape of the cornea. If I speak about the improving the stability of the cornea, now of course the stability of the cornea is maintained through the cross-linking. Now any patient once diagnosed as having keratoconus, we should determine whether he has progressive keratoconus, so that we will decide to do cross-linking for him and determine whether he is good candidate for cross-linking or not, and determine what type of cross-linking techniques we are going to do for him, the classical Dresden protocol or the accelerated protocol or the customized cross-linking and so on. We will go through these details in the lecture of cross-linking, but we should go through this step before doing any subsequent step in the management of the case. We cannot do any procedure without maintaining the stability of the cornea first. Now we come to the second step in the hierarchy of modern keratoconus management, which is the improvement in the shape of the cornea or in the topography of the cornea. And by improving the shape of the cornea, we regularize the cornea by whatever means that we'll explain later on. This to much extent will help to improve the visual quality of the patients by reducing the high order aberrations and improving the uncorrected visual acuity of the patients. So this is one of the major target in the management of patients with keratoconus, to regularize and improve the shape and topography of the cornea. And this is perhaps the main use of the intracorneal segments or the intracorneal intrastromal corneal ring segments, is to regularize and improve the shape of the cornea. So by doing this stabilization of the shape of the cornea, that's the topography of the patients, so we are dealing with the high order aberrations, so that we can improve the visual quality of the patients. And this regularization of the shape of the cornea can be done by different techniques. One of them is the intracorneal ring segments or the tissue inlay, as we will explain later about them, either the CAIRS or the Kera natural or the customized inlays. So we will speak about this in later, or the use of topography guided or wavefront guided laser ablation to improve the shape. Once we improve the shape, we are dealing with the high order operations, which is the main one of the main important targets in patients with keratoconus who is suffering from the coma, mainly the vertical coma and the secondary astigmatism and the excessive spherical operations. So by doing this, we are dealing with the high order operations. So this is very important. So as a general, the use of intracorneal rings, we are strengthening the cornea, and also we are changing the shape of the cornea, and we are dealing with the operations of the patients. And at the end, we will have improvement in the uncorrected visual acuity. Now you should memorize that intracorneal ring segments is not a refractive procedure, although it has a refractive impacts, but it's mainly to improve the strength in the cornea and improve the shape of the cornea. And by improving the shape of the cornea, we are reducing the high order operations and improving the visual quality of the patient. So you shouldn't promise your patient that you will be a glass independent. He will need to use the glasses to further tune and fine his visual function and dealing with the low order operations. By low order operations, I mean the spherical and cylindrical errors that the patient is suffering from. However, the large order or high order operations in the form of coma or secondary astigmatism or spherical operations due to the abnormal shape, we are dealing with the intracorneal rings to deal with this, although it has also some effect on the astigmatism and the spherical component of the refractive status of the patient. But this is not our primary target. Our primary target is to deal with the high order operations. Now we come to the third step or third stage in the management or the moderate management of keratoconus, which is the improvement in the visual function. Now you should remember that both the maintaining the stability of the cornea and improving the shape of the cornea, to some extent, this will improve the uncorrected visual acuity. And this is one of the major targets in dealing with our patient is to improve the uncorrected visual acuity. Why? Because the corrected visual acuity is dealt here in this stage by improving the visual function using whatever available weapons to improve or fine tuning of the vision of the patient. So the aim of the first step and the second step is to improve the uncorrected visual acuity, but the aim of the last step to improve the corrected visual acuity. And that's why you should never tell your patient that you will be a independent for glasses or vision glass independent. He still will need to use his glasses or his contact lenses because as I said, the fine tuning is a last step. Both the first and second steps just they will improve the uncorrected visual acuity, but the corrected visual acuity is improved in the last stage. We have different types of weapons that we can fine tuning the visual function of the patient, including the use of hard contact lenses. There are very different types of contact lenses like the hard contact RGB or the scleral contact lenses or the hybrid lenses and many types of contact lenses. Of course, we shouldn't forget the glasses. Still, we are sometimes in need for the glasses. Also, we need to fine tune his vision by the use of PRK or using the lens implantation for coexistence of myopia. And as I said, that we can use these steps separately or we can use them in combination. So that we can use each one of these separately, like the cross-linking or the improvement the shape, or we use them in combination, that we use intracorneal rings along with the cross-linking, or we use topography guided ablations with the cross-linking and so on. So this is the general frame and the general guidelines that we should pass through, that we have to improve the stability first, then improve the shape of the cornea, and then fine tuning his for his visual function. The use of intracorneal ring segments dated back to the 1949 by Mr. or Dr. Barry Kerr, and after that it undergoes a huge upgrade and new generations. As you can see from this time line, most of the doctors that contribute to the upgrade and the innovations in this technology. and huge advancement seen in the last 10 years with the emergence of the asymmetric intracorneal rings, and also the use of CAIRS, that's the allogenic graft by Suzanne Jacob. And that's why the use of intracorneal rings is still valid and very effective in reshaping the cornea as an additive material. So this is briefly the timeline for the evolution of the intracorneal rings from 1949 up to now. As far as the different types and the different generations of the intracorneal rings or intrastromal rings, as I said before, there are different varieties: the Kira rings, the Ferrara rings, the Intacs, the Mayo rings, and the Visium rings, and the CAIRS. Now, the difference between them that most of these are BMMA synthetic intracorneal rings. Only CAIRS is from natural allogenic graft from the cornea. We will speak in details about the CAIRS because now this is a trend in the management of keratoconus. The others, we will not speak on details about the different nomograms for each one. Generally, the Kira rings, the Ferrara rings, and the Mayo rings are triangular in shape. Intacs are hexagonal in shape, and Visium is quadrangular. However, the CAIRS, as I said, is from allogenic graft. As far as the shape and of the intracorneal segments, there are different types. There's symmetric rings, symmetric in the sense they have the same thickness all over the arc of the segments, and we have different arc length and different thickness based on the required correction of astigmatism or myopia. And also there is what's known as the progressive intracorneal rings or the asymmetric rings, that they have variable thickness along the arc of the segments and different curvatures. And this is also useful in correcting irregular types of keratoconus, and especially the dot type and the what's called the croissant type, so that it will improve the myopia as well as the high order aberrations. This is Paulo Ferreira, and this is Jean Reynolds from USA. This is the inventor for the Intacs, and this is the Paulo Ferrara, the inventor for the Ferrara rings from Brazil. And as I said, that now the new trend is the CAIRS, which is invented by Suzanne Jacob. This is a natural or is a synthetic allogenic graft from the cornea. This is the graft. That is, it has a circular appearance. Special trephine use it to construct this graft, and this is the way how it is implanted inside the cornea. We will speak in details about this CAIRS. Also, we have the Kera natural, which is from preserved tissue. That the tissue of the cornea is preserved in such a way so that we can use it after a long time. Invented by Alina Clicci. And also nowadays there's what's called the customized tissue addition, using what's known as the CTAK. Customized by using the femtosecond. So we have different thickness and different shapes to correct the different refractive errors in the cornea. So we will speak later about the CAIRS in details. The intracorneal ring segments or the intrastromal corneal rings are originally developed to manage myopia, and then also started to use it in the management of astigmatism. That's why it has great application in the management of keratoconus. And they are made primarily from BMMA materials, and which are highly biocompatible and nearly having the same refractive index as the cornea. And the measurements of the segment are as follow. We have the arc length. This is the arc length, which is measured in degrees from 90 degrees, 60 degrees, and so on. And this length is very important to contribute to the power of the segment. So the more the length, the more the effect, and the more the length, it will have a effect on this spherical component of the refractive error. The smaller the length will be a greater effect on the astigmatism. And we have the apical diameter, which is the optical zone. This is the apical diameter, usually between 5 to 6 millimeter. The smaller the optical zone or the apical diameter, the more powerful the segments, and the larger the size, the less powerful. And the size is dependent on the mesopic size of the pupil. So if you have small pupil size, you can use 5 millimeter optical zone segments. And if you have a large pupil, better to use the 6mm size, so that to avoid the edge effect of the segments and the glare that can be induced by the edge effect of the segments. Then we have the inner diameter and the outer diameter, and the difference between them. This will give us the base of the segment, usually 500 to 600 microns. And then we have finally the thickness of the segments. The more the thickness is of the segment, the more the power and the effect of the segment. So if we have more thickness, we have more power. If we have small optical zone, we will have more power. If we have more arc length, we have more power. And if you have small arc length, you mainly affect astigmatism rather than the spherical component of the refractive error. Now, as far as the different intrastromal corneal rings available in the market, there are plenty of types. We will not speak in the details of each type. However, broadly speaking, we have the Kira rings and the Ferrara rings, both from Brazil, and Intex, Mayo rings, Visium rings, and the CAIRS. Now, the broad difference between Kira rings, Ferrara rings, and Mayo rings, all of them are triangular in the cross section, and the Intex are hexagonal in cross section, and Visium is quadrangular in the cross section, and CAIRS is in corneal allogenic intracorneal ring segments. That's an allogenic graft. This is a piece from corneal tissue. This is invented by Susan Jacob from India, and this is the latest generation of the intracorneal rings. Other rings are all made up of PMMA rings, and each ring, they have their own nomograms for implantation. And my rings mainly use it for the treatment of myopia. And the triangular one, which is the Kira ring, Ferrara rings, and the Mayo rings, because of the triangular effect, they utilize the prismatic effect so that they overcome the glare and halos that's induced by the segments or the edge effect of the segments, especially in people with large diameter or at night. So by this way, so the rays will come and stuck or hit the segment and reflect it back, so that there will be no glare encountered due to the edge effect of the segments. Now, broadly, what's the mechanism of action of the intracorneal ring segments? According to the Barrier thickness law, which states that to flatten the cornea or flatten the central part of the cornea, you have either two procedures, either an ablative procedure using the LASIK, or an additive procedure that is used or implant the intracorneal ring segments. By this way, you flatten the central part of the cornea. And according to the Blavatsky, the flattening effect of the intracorneal ring segments increase as we increase the thickness of the segment or decrease the optical zone of the segments. That's to say that if you have an ring segment implanted 160 degree 300 micron segment implanted at a 5 millimeter, this will generate a greater effect than same segment but with a thickness of 200 micrometer and implanted at 6 millimeter. Why? Because when we increase the optical zone, the effect will be reduced, and the smaller the optical zone, the more effect. And also the thickness, the smaller the thickness, the less will be the effect. And generally, the arc length is related to the cylinder correction. The smaller the arc length, the more the cylindrical component of the correction, and the larger the arc length, the more is the spherical component of the correction. That's why the Mayo rings, which is around 340 degrees, is mainly used for the treatment of myopia. Now, another proposed mechanism for the effect of the intracorneal rings is what's known as the creation of a new limbus formation. Now, this new limbus formation based on the fact that collagen fibers builds frame or support of the stretching from the limbus to the limbus. So during the tunnel formation, when we do the tunnel in the cornea, either manually or by femtosecond, the collagen fibers at the tunnel will be cut, and this will lead to concentration of the peripheral fibers will be retracted back and damaged, and outside the tunnel, and the proximal fibers will be attached to the intracorneal ring segments, and this will create a ball or as if there is a new limbus formation, and this will lead to flattening of the central part of the cornea. This is the mechanism of the new limbus formation that can be a reason for the flattening effect of the intracorneal ring segments. Again, this slide explains in detail the arc flattening effect of the segments. As you can see here, that the more the thickness of the intracorneal ring segment, the more the centripetal effect, and the more the diameter, the less is the centripetal effect. So this is an inverse relationship. If you want to increase the effect of the rings, you have to increase the thickness. If you want to decrease the effect, you can increase the diameter. And similarly, as far as the arc length of the segment, if you increase the arc length of the segment, the effect will be towards spherical equivalent. And if you decrease the arc length of the segment, this will be more effect on the astigmatism rather than the spherical component of the refractive errors. So this is the Barry-CAIRS law in detail. So it is very important that to have a good vision, you need to have a good shape, not a good refraction. So the main target and the main aim of the intracorneal ring segment is to improve the shape of the cornea. And as I said before, it is not a refractive procedure, although it has a refractive impact on the refraction of the patient. But the main aim is to improve the shape of the cornea. Now, to understand in details the effect of the flattening effect of the intracorneal rings, you should understand that in keratoconus, for example, like in this picture, we have both steep meridian in this direction and we have a flat meridian in this direction. And usually we implant the intracorneal rings to straddle the steep meridian so that this will create a traction force in the cornea, and this will lead to the flattening of this steep meridian. So the rings will be implanted like this. Another effect is that in the middle of the center of the body of the segments, there will be a skew movement, so that there will be some sort of rotation, mild rotation, and this will lead to steepening of the flat meridian, which is this one. So you have a combination of both the flattening of the steep meridian and the steepening of the flat meridian. You can see here, this is the from lateral view of the segment. Now there will be more steepening of the cornea due to the skew movement that happens in the middle of the body here. So this is a combined effect lead to the desired refractive result. However, this is sometimes not predictable, and especially that we are dealing with abnormal cornea, we don't know the exact biomechanics that what happened, but this is generally how the mechanism, the intracorneal rings will flatten the central part of the cornea. So in general, to summarize, that if you look at this picture, if you have this like this is a steep cornea, now if you put spacer here, now this will pull the rope, this one, and this will cause more flattening of the central part of the cornea. Similarly, if you have a rope connecting these two trees, so the rope will be falling down and touching the ground, but when you put spacer here, like the intracorneal rings, so this will pull the rope above the ground, so that this is the flattening effect that happens due to implantation of this intracorneal rings. And this flattening effect is proportional to the spacer that you have, you place, and based on the thickness, how much thickness you place, the more there will be the flattening effect. Now we will speak about the indication of intracorneal rings. As we said at the beginning of the lecture, that the aim of the intracorneal rings is to improve the shape of the cornea and the topography of the cornea. It is not a refractive procedure, but it has a refractive outcomes. But the main aim is to improve the shape, and when we improve the shape, we will eliminate to a large extent the high order aberrations, and we will improve the visual quality. So one of the main indication that if you have a patient with the poor best corrected visual acuity, and when we say best corrected visual acuity means with the glasses of less than 0.6, and with a good visual potential tested by contact lenses or by pinhole. If the patient can improve another 2 lines beyond the best corrected visual acuity, so this is a good candidate for intracorneal rings. Another main indication is the presence of intolerance to the contact lens because of the high irregularity in the surface. So this is a good candidate for intracorneal rings. The cornea should be very clear and there is no striae in the cornea. And the corneal thickness at the tunnel side should exceed 450 microns. And within the optical zone of 5 to 6 millimeter, at least 400 microns should be there to guarantee the security and the effect of the intracorneal ring segments. Another thing that the K2 value, that's the steep meridian, should not exceed more than 57, and the Kmax should not exceed more than 70. The Kmax reflects the anterior surface. So if there is very high irregularity of the anterior surface, this indicates that the patient there will be no improvement and better to go for another procedures. So this is the main indications for the use of the intracorneal rings, as I said, mainly meant for maintaining the topography and the shape of the cornea. Now, if we speak about the contraindication for the intracorneal rings, there are a lot of contraindications. Among them is the advanced cases. As we said before, that intracorneal rings for mild to moderate cases, but if you find advanced cases in the sense of K2 value more than 57 and Kmax more than 70, and you have very steep cornea with very high Q value, all these are not good candidate for intracorneal ring segments and better to go for keratoplasty or other options. Another thing is the presence of corneal scarring. Any sort of corneal scarring or corneal striae is another contraindications. If you have very thin cornea, less than 450 at the tunnel side or less than 400 at the within the optical zone, this is another contraindication because the thickness will not be sufficient to secure safe intracorneal rings, and also is not sufficient to achieve the desired effect of the intracorneal rings, that's the flattening at the center. Another thing, as I said, the very steep cornea with very high Q value is another contraindications. And if you have pregnancy, is a contraindication for the intracorneal rings, or any systemic diseases, especially autoimmune diseases, is another contraindication for the intracorneal rings. But the main thing is that if you have advanced keratoconus, this is a contraindication for the intracorneal rings. After we have discussed the indications and the contraindications of intracorneal ring implantation, and we understood the aim of the implantation of the synthetic intracorneal rings in a patient with keratoconus, which is mainly to improve the topography and the shape of the cornea so that we can eliminate to a large extent the high order aberrations and improve to a large extent the uncorrected visual acuity. So we have to do detailed refraction of the patients, mainly manifest refraction. We have to do topography and determine the pachymetry and the shape of the cone. Also determine the axis of the topographic axis. Also, we need to do the apparometry and determine the type of aberration which is predominant in patients with keratoconus and determine the coma axis. We have to measure the pupil in the mesopic situations. And also we have to apply the nomogram according to the type of the rings that we are going to use, and then finally to determine regarding the surgical procedure, the location of the incision, the tunnel size and site, and the location and the safety of this tunnel. Now we will go in the details of each one of these steps and study them in more details. We'll start with the refraction or the manifest refraction. As you know, in a patient with keratoconus, sometimes it is very difficult to do refraction for the patients, and we should not depend on the objective refraction that is done by the autorefractive keratometer, because most of the time it is difficult to get any reading, and it is also unreliable. So we will basically depend on the manifest refraction of the patient and determine the manifest sphere and the manifest astigmatism and the acts of the astigmatism on a clinical basis and on a clinical background. In the next slide, I will speak in details how to do the proper subjective or manifest refraction to the patient to determine the power of the sphere and the power of the cylinder, as well as the axis of the cylinder. Now we come to an important step in the refraction of patients with keratoconus, which is known as the subjective refraction. And this is very important because most of the time patients with keratoconus with irregular astigmatism, it is not easy to do refraction with the ordinary autorefractive keratometer. And in this time, you should depend on your subjective refraction to determine the best corrected visual acuity for your patient and give him the ideal glasses for him. And this is also important to determine what's the potential visual acuity of the patient so that you can decide what type of treatment you are going to offer to your patient. when you have a good idea about the potential visual acuity of your patient, so you can decide whether you can improve the quality of his vision by doing laser correction for the high order operations, or by improving the shape of the cornea by using the intracorneal rings. So determining the potential visual acuity and the subjective refraction is very important in patients with keratoconus. Now, there are certain steps that you should follow to do the subjective refraction. First thing that you have to determine the unaided visual acuity first. For example, in this patient, this is the unaided visual acuity without any correction. Then you go 2 lines above. So start concentrate on this 2 line. Ask your patient to concentrate on this line. And of course, we will use the stenobic slit. By this stenobic slit, we want to determine meridian by meridian, the 2 principal meridians of the patients. We should determine the power needed to have the best visual acuity through this meridian, and then we verify the X by minor rotation and ask the patient whether he see very good vision or not. Then after that, we will verify the power of this meridian by adding minus lenses and see what's the best visual acuity for this patient. For example, if you use this is the X of the stenobic slit, and determine the best X the patient can see, and then we will do fine tuning so that determine the best X, and then we will verify the power of this X by adding the minus lenses. By rotating the lens like this, the patient will say whether he has better vision or not, so that we will do fine adjustment for both for the X as well as for the power. So as I explained before, after we determine the unaided visual acuity, and we do fine tuning for the X of the stenobic slit, so we determine the best meridian the patient that can see using that meridian. This is known as verification of the X. But after verification of the X, now as you can see how we fix the stenobic slit in the trial frame, and we do fine verification. This maneuver done by you or by the patient himself to determine the best meridian that he can see with minimum glare and disturbance in the image, so that the best meridian he will stop at that level. Now we come to the stage, we determine this meridian. Okay, now then we come to the stage of verification of the power. Now fixing the trial frame on that meridian, we start by adding, for example, the -1 lens and determine the visual acuity of the patient. And after that, we increase the power of the spherical lens to -2 or -3 and see how much the visual acuity will improve to this patient. For example, he improved up to this level. So, and we don't forget the meridian that the patient is seeing. For example, now we add -2, so the vision is improved to some level. Then we add -3, as you can see here. So he improved, for example, to 6.9 or 6.6 vision. So this is the best meridian for this patients. This is the best power. So we have verified the X and we have verified the power. And we fix this meridian as this is the best principal meridian at this direction. That's 30 degrees. Now the next step will be that we rotate the stenobic slit 90 degrees perpendicular to the first meridian, so it will be 120 degrees, and do the same thing starting with from where we end. We end at -3, we start with -3, then -4, then -5, and determine the best visual acuity in the other principal meridian. So we determine the best power in the 2 principal meridians, and we determine this meridian is the 120 degrees. So we have -3 diopter sphere at 30 degree meridian and -5 at 120 degree meridian. Now we regard this as a sphere power -3, and the difference between the 2 meridians will be -2. So the needed glasses will be -3 sphere, -2 cylinder, but we need it to work in this meridian, so it will be in this X, that's the 30 degree. So the final prescription will be -3 sphere, -2 cylinder at 30 degree. Okay, this is the final prescription of the patient. This is the way how we do subjective refraction. Now, after we have finished the subjective refraction and determined the power of the sphere and the cylinder and the X, we come to the next step, which is the topography, and study certain important information help us in the planning for the intracorneal ring implantation. In the topography, there are three important points that we have to discuss and elaborate in the topography. First thing that we have to determine the topographic X. As we said that in the subjective refraction, we determine the manifest X, but now we have also to determine the topographic X. The second thing, we have to study the location of the cone. The third thing is to study the pachymetry. Now, in the topography, first we have to look to the tangential map. Tangential maps gives more detailed information about the astigmatism. So make sure that we are looking to the tangential map, and then we determine the steep X. Now we have to determine the steep X. Now we have the K1 and K2. K1 reflect the flat meridian, and the K2 is the steep meridian. And as you can see here, the degree which is written in the pentacam printout is the degree for the flat meridian. So now the flat meridian it has 5.3 degrees. So the steep X will be perpendicular to it. So it is around 95, as you can see here. So this is the steep X of the astigmatism in this topography. And after that, as I said, you should make sure that you are in the sagittal map. Now then we shift to the elevation map. And from the elevation map, we have to look for the location of the cone by drawing the topographic X. Now you look to the shape of the cone and determine which of these nomograms it is correspond. As you can see in this case, it is corresponding to the nomogram A, so that it is similar to this one. That is nearly 90% falling below the topographic X, like this, like in this case. So by this way, we determine which nomogram we should follow to determine the thickness and the arc length of the intracorneal ring segments. Now, the third point, after determining the topographic X and determine the shape of the cone and determine which nomogram we are going to use, we have to determine the pachymetry with the same topographic X, so that it is important to determine the thickness of the cornea in the tunnel where we are going to do the tunnel, and the thickness of the cornea in the central part. As we mentioned in the indication, a minimum 450 microns should be in the tunnel area, and in the central part minimum 400 micrometer. So this is very important to determine the pachymetry map. So we have to look to the tangential map for the topographic X and elevation map for determining the shape and location of the cone, and for the pachymetry map to determine the thickness of the cornea. By doing the topographic analysis of the patient for planning for the intracorneal rings, the topography gives us an important information, three main important informations. We have to determine the topographic X by looking to the tangential map, and also we have to determine the location of the cone and the shape of the cone by looking to the elevation map, and we have to determine the thickness of the cornea centrally as well as in the area of the tunnel by looking to the pachymetry map. And these are the needed information that while we are planning for the intracorneal ring implantation. Now, for the topographic X, as we have explained, by subjective refraction, we have determined the clinical X or the manifest X, but we have also to determine the topographic X to compare it with the clinical X. The topographic X represent the steep meridian, where we have to implant the rings straddling this meridian to benefit from the flattening or the centripetal flattening of the synthetic segments. Now, I remind you that in the topography printout, the K1, which is the flat meridian, and the K2 is the steep meridian. The degree which is placed here is the degree for the flat meridian. So like in this example, it is 5.3 is the flat meridian. So the steep meridian will be perpendicular. So it will be 95 degree, which is corresponding to this topographic X. This topographic X is very important. I will explain later the importance of the topographic axis, that it will determine the location of your incision as well as where you are going to place your segments. Now, the other thing, as I said, we have to look for the elevation map, especially the anterior elevation map, because the intracorneal ring segments mainly affect the anterior surface of the cornea and improve the topography of the anterior surface of the cornea. So we have to look to the anterior elevation map to determine the location of the cone and the shape of the cone, so that we can compare it with the nomogram for whatever intracorneal ring you are going to use. For example, in this case, if we apply the topographic axis, so we can determine the shape of the cone and compare it with the nomogram, which correspond to which one of these. In this case, most likely it corresponds to this. So it determines how far is the apex of the cone from the central part of the cornea. For example, if we are planning to place the intracorneal rings, it will be like this picture. Now, the last thing is the bathymetry map. We have to look for the central bathymetry, which is, as we said in the indication, a minimum 400 microns, and also the bathymetry along the tunnel location, which is a minimum of 450 is needed to safely guarantee the effect of the intracorneal rings and avoid any future complications. So you can see that in this case, we can use the nomogram A, which belong to this shape. We'll explain later about the nomogram in details. Now, there are other pictures for the shape of the cone that can be like this nibble cone, or it can be like this shape, which is known as crescent or croissant, or like this symmetric bow tie. And each one of them has its own nomogram, comparing with these pictures, so that we can implant the corneal rings that's needed. For example, this case, we need two segments like this to improve mainly the astigmatism. And for this one, we need a large segment with large thickness to improve the irregularities in this direction. And for nibble cone, we need large ring to improve the aberrations and the spherical, mainly the spherical aberrations present like in this case. In the next slides, we will speak about the nomogram and the different types that's used for different type of rings. Now we come to the third important step in the evaluation for intracorneal ring implantation, is analyzing the aberrometry of the patient and determine the level of high order aberrations. Now we come to the next step in the preparation of the patient for implantation of the intracorneal ring, that we have to study the aberration profile of the patients. This is very important for managing the high order aberrations. As we said before, that the indication for the intracorneal rings, among the indications, is to improve the surface topography of the cornea. And by improving the surface topography of the cornea, we reduce the high order aberrations. This is the primary target. And improvement in the uncorrected visual acuity and the other aberrations, that's the low order aberration, is secondary target. However, primarily we are targeting the high order aberrations, because the sphere and cylinders can be improved by glasses and by soft contact lenses. However, the high order aberrations cannot be improved by the soft contact lenses or the glasses. They need either rigid gas permeable contact lenses, or the intracorneal rings, or other means like the topography guided or wave front guided ablations. So as we have spoken before in the lecture of topography and aberrometry in my lecture series before, this is the what's known as Zernike polynomials, and this is the profile of the different aberrations that the patient can see. This is the low order aberrations, which is the first and second order aberrations. This is the low order aberrations. However, from the third aberration, this is the high order aberrations. Now, patients with keratoconus, commonly they complain of coma. This is one of the most common aberrations in patients with keratoconus. Commonly the vertical coma, and this is the horizontal coma, and this is the spherical aberrations. Usually when the cone of the patient in the conic cornea is central, mainly he complains of excessive spherical aberrations. However, when there is eccentric cone or decentric cone, there is commonly vertical coma. Other aberration can be like trifoil and tetrafoil. So this is the common aberration that patients with keratoconus will suffer from. Now, if we classify, as I said, the high order aberrations, this is the low order aberration. This is the most common, and about 10% is high order aberrations. The low order aberrations is the sphere and the cylinder and the defocus, which is corrected by glasses. However, the high order aberrations, commonly the coma, the vertical coma, trifoil, and excessive spherical aberrations. And this is the most common high order aberrations. Among the high order aberrations, this is the three most common aberrations seen by the patient with keratoconus. And this is the point spread function, how the patient with aberrations can see the light in patients with keratoconus. Now, if we study in details the vertical coma, this is the vertical coma. We will study the next slide, the details regarding the negative vertical coma and positive vertical coma. This is a negative vertical coma. Vertical coma, why negative? Because the inferior part is more powerful than the superior part. Okay, and this is how the patient will see the point spread function. So that this is the halos and that's seen by a patient with vertical coma, and this is the aberration profile. This is very important because we have to determine the coma X. Now, when the patient have excessive high order aberrations, more than 0.4, so we have to determine the coma X and see whether it is consistent with the manifest X or the topographic X or not. Now, we have three axes in a patient with intracorneal rings. We have to determine the manifest X or the clinical X, and the topographic X, as we have explained before, how to determine the steep meridian. And finally, if the patient has high order aberrations, we have to determine the coma X, so that we will decide where will be the location of the intracorneal rings and where is the incision site. Now, if the patient is lucky, you will find the three axes coincides together, or at least within 25 to 30 degrees between each other. This will be, to some extent, is okay. The problem arises that if you have discrepancy between the coma X and the topographic X, and if the patient has high order aberration, so you may sacrifice for the topographic X and you place the intracorneal rings along with the coma X. Some people, they advise to place the ring in the intersection between the topographic X and the coma X. Now, we'll study about this later, but this is just, I like it to show you how the aberration profile appears for patients with vertical coma. So that, like in this patient, this is the X, the coma X, so that the ring will be placed in such a way so that along with the coma X, especially if he has high order aberrations. And from the aberration printout, aberration profile, we can determine the coma X. This is very important among the analysis of the aberration profile of patient with keratoconus. Again here, speak more about the vertical coma. As I said, this is the vertical coma. This is called negative vertical coma because the inferior part is more powerful than the superior part. And this is usually typical in patients with keratoconus, that the inferior part is more powerful. So the patients with keratoconus, they have a negative vertical coma. This is the most common. Now, this is the reverse. This is a positive vertical coma in which the upper part is more powerful than the inferior part. And this is the for spherical aberration. This is the positive spherical aberration in which the central part is less powerful than the periphery. And this is can also seen in myopic LASIK ablation. Or this is the negative spherical aberrations in which the central part is more powerful than the periphery. And this is typically seen in keratoconus. So patients with keratoconus, they have a negative spherical aberration and also a negative vertical coma, negative vertical coma and negative spherical aberration. And this picture also can be seen in the hyperopic ablations. Also, you can see this picture. And this is also the profile. This is a horizontal coma. This is a vertical coma along the vertical axis. This is the horizontal coma. Now, this is the point spread function, how the patient will see the light with halos in patients due to the coma. And this will cause significant degradation of the quality of the vision of the patient. That's why he will not improve with the glasses, and you need to improve the surface of the cornea to improve his visual quality. Now, if you look to this topography map for one patient with the keratoconus, typically he has a hot spot in the inferior part, and this is asymmetric keratoconus in which it is decentered apex or displaced apex from the center. So this patient has the apex of the cornea nearly normal, and this is the cone appears inferiorly or paracentrally. So this patient, if you study the operation profile, you can see clearly that he has a negative vertical coma. This is the negative vertical coma, and this is because the apex of the cone is displaced inferiorly. Now, if the cone is present centrally, like the nipple cone, you mainly find spherical aberrations more. However, when you find displaced apex of the cone, you will find mainly vertical aberrations, and as I said, negative vertical aberrations is much more common in keratoconus. So like these patients with negative vertical aberration reaching to 1.8, which is too much high, and nearly very negligible spherical aberrations, as you can see here, because the cone is displaced inferiorly. So such patient, he need or he will benefit from the implantation of the intracorneal ring to improve this vertical aberrations. Now, this is the point sprint function, how the patient will see with these operations. And you can see after you remove the operations, how the patient vision will improve to this level. This is simulation done by the machine to show you when you remove these operations from the patient, what will be his visual functions. Now, the same thing as I said before, we determine the coma X. For example, in this patient, he has 1.3 coma and the X 283. So we determine the coma X from the operation printout, and then accordingly we decide regarding the implantation of the ring. So this is the steep X of the patients, so that we can implant the ring in the inferior part like this. And this is, of course, as I said, it depends on the nomogram. We will choose which nomogram, and it will gives you the thickness and the arc length of the ring, the appropriate ring that will correct the operation of this patient. Now we come to the fifth step in the preoperative evaluation for patients planning for intracorneal ring implantation, which is the pupil. Now we come to the another important parameter in the analysis of the case for implantation of intracorneal ring segment is the pupil size. Now the pupil size can be measured using the pupillometer or by pentacam, making sure that you are taking the size at the mesopic illumination so that you have taken the mesopic pupil size. Now, if you have a patient with large pupil size, more than 6 millimeter, this is contraindication for intracorneal rings, because the patient will suffer from the glare and halos due to the edge effect of the intracorneal rings. So better not to implant intracorneal rings. Now, if you have pupil size less than 5 millimeter, you can implant the 5 millimeter size intracorneal ring, the optical zone of 5 millimeter. Or if you have more than 5 millimeter but less than 6 millimeter, you can use the 6 millimeter optical zone ring segments. Now, as I said, that you have to make sure that you are taking the pupil size by the pentacam at the mesopic conditions. Now, sometimes patients more than 5 millimeter but less than 6 millimeter, the advantage of using the Ferrara rings as they are triangular and they have the prismatic effect. Now, this prismatic effect is very useful, that it prevents the edge effect of the segments, so that, as you can see, this is the shadow seen on the iris. And this shadow because of the total internal reflection done by the prism at the segment, so that the patient will not have a glare on and halos. So the rays come in and come out at the same time, so the patient will not suffer from the edge effect of the segments. This is one advantage of the triangular segments like the Ferrara rings. Now, after we have finished the speaking about the measurement of the pupil in the mesopic condition, now we come to the fifth step, which is the nomogram. As far as the nomograms for different intracorneal ring segments available in the markets, we have plenty of types, and each type it has its own nomogram. And the nomogram is subdivided based on the shape of the cone, and each shape of the cone there is specific nomograms. This is just an example of one of the rings, that's the Kira rings. This nomogram or classification named as Fernando Vega Alfonso classification, done by these two Spain doctors. And to apply the nomogram, you need to do refraction and determine the topographic axis and coma axis and all the information that I have mentioned before to be able to apply this nomogram. Another thing that nowadays everything is available online. What you need is just to log into the website of the company manufacturer, and you upload your topography and pachymetry and everything, and they will measure for you what type of ring, arc length of the segments you will implant, and what type of rings, is it symmetrical or progressive, and also the thickness of your ring. So everything is easy and is not difficult. So this Alfonso classification divides the shape of the cone based on to a reference topographic or coma axis, so that we will have different variety of keratoconus, the shape of the cone, croissant, dock, snowman, nipple cone, and bow tie, and each one of them has its own nomogram, and so that we can decide whether to use symmetrical rings or asymmetrical rings according to the nomograms. And this classification based on comparison of the shape of the cone relative to the reference meridian or X, that's the topographic or coma X, and so on. So this is just a example of the Kira rings, and these are the different classifications. For example, now this type, this is inside the nomogram, this type of keratoconus in relation to the reference surface, that majority of the cone falling below the reference surface. So in such cases, what you need is to implant a single ring, symmetrical ring in one side like this to overcome this steepness in the inferior part to the reference axis. Or sometimes if you have a very severe astigmatism, so you have to implant a corresponding in the next location another ring which is a small and less thickness to overcome the large cylinder. This is type 1 according to the Kira ring nomogram. Similarly, if you have symmetric cone like this, that's 50% of the cone present on either side of the reference axis, so that it is typical that you can, what you need is just to put symmetrical rings on both sides, and this will overcome all this steepness of the astigmatism. So this is just an example of the applications of the nomograms to manage different shapes of keratoconus. Come to the last step in the preoperative evaluation, which is we have to determine the surgical tunnel, where is the location of the tunnel and the location of the incision, and determine the depth of your tunnel, so that you can plan for the exactly where you will place your incision and how much the depth of your tunnel based on the thickness, and whether to do the procedure as manual technique or using the femtosecond laser. As we said before, that among the pachymetry analysis of the topography map, that we have to look to the thickness of the cornea at the area of the incision, because for implanting the intracorneal ring, we have to reach to 80% of the thickness at the tunnel area, and a minimum safe corneal thickness at that area should be at least 450 micrometer. So we can determine the thickness at that area. This is the location of the incision. And as you can see, the thickness is 469, so 80% of the thickness will be around 375. So if we are doing the manual technique, we have to adjust the calibrated diamond knife to be of a thickness 375 microns. However, nowadays, with the use of the femtosecond, the tunnel is easily formed with the femtosecond laser procedure, and it is very predictable and very safe using the femtosecond technique, as you can see in this operation. And after the tunnel has been created, now there will be using the dissector to facilitate the entrance of the intracorneal rings. And here, post-operatively, you can see the patient very clearly implanted. This is not the same patient, this is another patient, but how you can see clearly the rings are concentric around the pupils. As I said earlier, that by analyzing the topography map in a patient planning for intracorneal ring implantation, we have to concentrate on the three main axes, that's the refractive axe and the topographic axe and the coma axe, and see whether they are coincidental or non-coincidental or perpendicular to each other. This is very important to plan for your incision site and also for the placement of the intracorneal ring, and you can correct both the astigmatism as well as the high order operation in the same setting. Now, if they are coincidental, it means they are close to each other and falling within 30 degrees from each other, like in this case, or non-coincidental if they are falling within 30 to 60 degrees. For example, this is the coma axis is non-coincidental with the other axis, or it is perpendicular if it is away from each other. So this is said to be perpendicular. Now, the patient will be lucky if the three axes are coincidental, so that when we place the rings, so that this will correct the astigmatism and the regular astigmatism as well as the coma operations, and the patient will has significant improvement in his vision quality. However, if there is divergence or discrepancy between these axes, now we have to sacrifice for one axe and look what's the main problem. If the patient has high order operations, we will place the ring based on the coma axe, or some doctors, they say that you find the intersection between these two axes and you place your rings. So this is very useful analysis point in the topography when analyze the patient for intracorneal ring implantation. Now, another important aspect in determining the location of your incision and is to determine which axe you are going to correct, the steep axe. Whether you are will depend on the topographic axe or clinical axe or coma axe. Generally stated that if the visual acuity is good in your patient with the best corrected visual acuity more than 0.6, you can rely both in the clinical axe and topographic axe, and usually both of them, they will coincide to each other plus minus 30 degree apart. However, if your patient has high order aberrations and with poor visual acuity less than 0.6 with high order aberrations, and the root mean square is high more than 0.4, at that time you should rely on the coma axe rather than on the topographic axe. So it is as simple as that. If your patient has central cone or nipple cone with minimum high order operations, he's mainly have irregular astigmatism, so you can depend on the topographic axe or the clinical axe. The clinical axe sometimes is not easy to determine clinically, so you will depend on the topographic axe. You determine the steep axe so that your incision will be on the steep meridian. However, in the presence of eccentric cone or paracentral cone, or what's known the dog type or the snowman type of keratoconus, at that time you better to rely on the coma axe, because you will find a huge discrepancy between the coma axe and the topographic axe. Sometimes they are perpendicular to each other. So the many studies shows that if you rely on the topographic axe, the patient will not happy, because you only will improve the spherical component and the astigmatism, but not the high order operation. And as we said, that the intracorneal stromal ring is meant mainly to improve the shape and the topography of the cornea and to increase the quality of the vision by removing the high order aberration, which is commonly the vertical coma and the excessive secondary astigmatism and spherical aberration, but mainly the vertical coma. So to summarize, it is like this. If you have high order aberrations, rely on the coma axe. If not, you can rely on the topographic axe. And I will give example here. Now, this is the refraction of one patient. He has this is the refraction with negative cylinder. We have to transpose it to the plus cylinder, because to determine the steep meridian, we have to convert to the plus astigmatism. So the axe here will be 100 degree. This is the clinical axe, or the clinical axe of this patient. You can see in this picture. So now if we look to the topography of this patient, this is the K1, which is the flat meridian, is corresponding to the 5 degree. So the steep meridian will be perpendicular to this, will be at 95. So you can see that the clinical axe is 100 degree and the topographic axe is 95. So nearly coincide with each other. So in this patient, there will be no problem if you use the topographic axe. and at that time, if you implant the symmetrical rings, it will be like this. But we discovered that this is a snowman type of cone shape, and you know that the snowman type has usually belong to the asymmetric type of cones, and it will not benefit from the symmetrical rings. If you place the symmetrical rings, you will improve only astigmatism, but not the high order aberrations. So this patient, when you look to the coma X for this patient, you can find that the coma X is far away from the topographic X. So to have a better visual quality for this patient, better to rely in this coma X, not in the topographic X. This is the topographic X. So we use the asymmetric intracorneal rings or the progressive intracorneal rings. This is a progressive. Progressive means that they have variable thickness from the beginning to the end, with the progressive increase in the thickness or also progressive increase in the arc length, so that you can improve both the astigmatism as well as the high order aberrations. So this patient, if we could make the rings on the coma X, the direction will be changed like this, and this patient will be happy with this result because you improve both the astigmatism and the high order aberrations. Now we will speak about important classification, which is known as surgical classification. By surgical classification of the keratoconus, this will help us to plan our selection for the type of the segments that we are going to implant, and also will help us to determine which X we will rely mainly. So broadly, keratoconus is classified into symmetrical cone and asymmetrical cone. Asymmetrical cones, the one which is, has paracentral and peripheral cone, like the snowman cone or the duck cone or the pellucid-like cone. However, the symmetrical cone, usually they have the central or paracentral cone, which is the nipple cone, croissant, and the bow tie, symmetric bow tie cone. This is usually a symmetrical cone. Now, the classification is important because for the symmetrical cone, it is preferably that we use the symmetrical intracorneal ring segments. However, for the asymmetrical cone, we preferably use the progressive segments or progressive intracorneal segments. Why? Because in the asymmetrical cone, now this is the high order aberrations will predominate, and the vertical coma, as we have spoken before, especially the negative vertical coma will predominate. So in these patients, many studies then shows that they will not be happy after the implantation of the symmetrical segments. However, for the symmetrical cone, if we implant them as symmetrical segments, we are targeting mainly the regular astigmatism and to some extent the spherical aberrations. However, in the asymmetrical cone, we are targeting the vertical aberration. So this is very important surgical classification to help you to plan what's your intended X that you are going to use, and also what type of segments you are going to use. So as I said, that the symmetrical cone, we use the symmetrical rings, which is the symmetric bow tie, the croissant, and the nipple cone. We use the symmetrical rings. For example, like this, it can be one segment or two segments. For this one, because we are targeting the astigmatism, so we use two segments that straddle the steep X. However, in the crescent shape or the croissant, we use one large segment on one side, or sometimes two segments to handle astigmatism as well. And for nipple cone, better to use single ring with large arc length, so that we will overcome the spherical aberrations as well as the astigmatism. So this is the topography appearance, how we are targeting here the topographic X for these cases. Now, for the progressive or the asymmetric cones, preferably we use the progressive intracorneal rings or the asymmetric cones. What are the types of the asymmetric cone? Is the snowman type, the duck type, and the pellucid-like. So in these cases, as you can see, we have progressive segments that has different thickness from the beginning to the end, or it has bilateral thickness, that is the thickness in the beginning and the end the same, but in the middle is high. So we can select the appropriate nomogram, and accordingly we apply the segments in relation to the coma X. This is the coma X, so that we will counteract the high order aberrations and improve the vertical coma, and the patient will have better quality of his vision. Similarly here, this is another example of two different types of keratoconus, the duck type and the snowman type, and both of them, they belong to the asymmetric keratoconus, as I said before. And in these two types, better to follow the coma axis to correct the coma axis rather than the topography axis. As you can see here, that there is a huge discrepancy. This is perpendicular. The coma axis, which is the white color, is perpendicular to the topographic axis. And also here, there is a huge divergence and discrepancy between the topographic axis and coma axis. So these two patients, usually they suffer from high order aberrations, and better to use progressive intrastromal corneal rings. And as I said, to place or to choose the wound location to be to correct the coma axis like this. And similarly, this one like this. And this doesn't mean that the both rings will be identical to each other. They are progressive according to the nomograms. So the use of progressive non-symmetrical rings will be useful to correct both the astigmatism as well as the high order operations. Now we come to the important point, which is what could be the intraoperative complications for the intracorneal rings. Of course, there is no 100% safe procedure. So there are some complications can be encountered by the surgeon during the operation for the intracorneal rings, and mostly due to a relation to the manual technique. Now, the femtosecond technique also has some complications, but it is rare as compared to the manual technique. Most of the described complications was during the manual technique of intracorneal ring implantation and the canalization of the cornea using the manual trephination. So the most common is the segment decentration, that the segment is not centered around the pupil, or incomplete tunnel formation, and this is seen in the manual as well as in the femtosecond technique. Also, sometimes there is incomplete tunnel formation. Extension of the incision towards the central visual axis or toward the limbus, sometimes due to the terminal ends is elevated, so that there will be extension toward the pupillary area or toward the limbus. Also, if you don't take proper measurement for the depth of your incision, there might be some shallow placement of the segment, and this might lead later on to the extrusion of the segment, or very deep segment that lead to endothelial perforations or false passage due to false canalization. This is the most common intraoperative complication that can be encountered. As I said, this is commonly with the manual technique, less commonly nowadays with the femtosecond technique. Now we come to the post-operative complications. The most common is epithelial defect that happens or occur post-operatively, which is commonly due to the instrumentations and the trauma during the surgery, and also the process of trephination and tunnelization. Also segment migration to the anterior chamber, as I said, due to improper implantation of the segment. So the segment might migrate to the anterior chamber, especially if it is deeply placed, or it might extrude superficially or outside when it is superficially placed. Also, corneal melting and stromal necrosis is a rare complication, and corneal thinning over the implant, and this lead to the ring exposure. Sometimes there will be necrosis of the stroma over the implant, and this will lead to extrusion of the segment outside due to thinning of the stroma. Also, epithelial plug at the incision site. Sometimes you will find down growth of the epithelium and from the incision side, and this epithelial ingrowth will go into the tunnel. Superficial erosions, corneal haze around the segment at the incision side, and focal edema around the segment. This is also an immediate post-operative complication that can be seen and can be managed by antibiotic and the use of steroids. Here are some of the picture that shows some of the complications that can happen after the intrastromal ring implantations. As I said, the sterile keratitis that can be seen with stromal haze, and also some deposits around the segments. These deposits might not disappear and might stay forever. And if detected early, this haze sometimes disappear with the use of topical steroids. Of course, among the complications is the infection. Sometimes there will be infection and contamination of the tunnel, and lead to abscess formation inside the cornea. Now, the other dread complications also is the extrusion of the segments from the cornea as due to superficial tunnelization of the cornea and continuous rubbing of the lid over the melting of the epithelium over the segment. So the segment will be extruded outside, and this lead to explantation of the segments. And this is commonly seen when sometimes there is a rotation of these two segments along the one of the axes, so that the terminal ends will be exerting pressure on the stroma and bulging from the cornea. This is like this effect. So sometimes preferably to use a single segment with large arc angle, so that arc length, so that avoid such complication of the extrusion of the terminal ends of the segments. Now we will go one step back and remind you what we have said regarding the modalities of managing keratoconus based on the stability of the topography and improving the shape of the cornea. We have spoken about the intracorneal rings as the synthetic rings, and another thing is the tissue lay, is the use of the tissue lay is the CAIRS and the CTAK. We will speak about this in the next slides. And as far as the other items, that's the topography guided and wavefront guided keratoplasty will be in separate lecture. So in the next coming slide, I'll mention just a few words about the CAIRS and the CTAK. Now we finish the synthetic rings and we come to a new area of the management of advanced keratoconus. Now we come to the recently invented natural implants. That's the CAIRS, which is invented by Susan Jacob, which is a allogenic corneal graft used as intrastromal ring segments made from human tissue and human cornea. These tissues are biocompatible and biointegratable because they are integrated within the tissue of the cornea, so that it will avoid all the complications seen in the synthetic implants like extrusion of the segments, and can be implanted in cases where contraindication for intracorneal ring segment, the synthetic implants like very thin cornea and very steep cornea, and in advanced cases, and also in steep corneas where there are some contraindications for synthetic intracorneal rings. Another thing that we don't need to go very deep in the cornea, it can be implanted more superficially because the risk of extrusion as seen in synthetic implants is not there, so it will have a greater effect because it is closer to the anterior surface of the cornea, and can be implanted over 360 degree. So this corneal allogenic intrastromal rings, which is called CAIRS, is a new trend nowadays, used in the management of advanced cases of keratoconus, and still the process, the technique undergoing further refinement and customization, so that it will be used in a wide range over the next years. Another thing that it is much lower risk complication, and they don't need to have a pre-existing corneal thickness of 450 or 500 microns as seen in synthetic implants. So it can be used in advanced cases of keratoconus and with minimum complications as seen in synthetic rings. So it can be implanted, as I said, superficially with greater effect on the anterior surface of the cornea, so it will improve the topography and the contour of the cornea. Now still there are nomograms growing on, so that it will be more predictable, and it has greater use in advanced cases of keratoconus. Now the indications for CAIRS, they have a huge indications, being on the top is keratoconus, but all any progressive disorder, so the ectasia and the cornea can be used, and can be done simultaneously with cross-linking or in a sequential step with the cross-linking, and very useful in cases where contraindication for cross-linking is there because of the thickness of the cornea. So the use of the CAIRS can be used to extend the applications of cross-linking, and can be implanted in patients with no document progression to improve the vision because of the flattening effect. So even there is no progression in the keratoconus, It can be used to improve the vision because it improves the contour and the surface of the cornea. So it can be also used in a wide range of corneal ectasis, especially in keratoglobus and pellucid marginal degeneration, and also in post LASIK cases. And it can also be used in treating the melting of the cornea and where there is extrusion of the synthetic segments. So as an alternative procedure, CAIRS may be a good option. Now, before I shift to a new area of management of advanced keratoconus, that's the use of tissue inlay in the form of allogenic graft or customized tissue inlay. I would like to mention some of the disadvantages of the synthetic intracorneal ring segments, namely the CTAKs and Ferrara rings and the Kira rings. Of course, the most common disadvantage is the complications, all type of complications that we have explained before in the form of infections or stromal melting and thinning and extrusion of the segments, and also corneal neovascularization. All are disadvantages of the synthetic intracorneal rings. Also, the problem of the indications and the strict boundary for the application of these technique in the management of keratoconus in the form of you have to have a minimum corneal thickness of 450 microns, and also the limitation for the curvature and the steepness of the cornea, that K2 should not exceed 57 and the Kmax should not exceed 70 diopter. All these limitations are disadvantages of the applications and limit the wide use of the intracorneal ring segments. Also, because of the risk of the extrusion, we need to go deeply in the cornea, up to 80% of the thickness of the cornea to implant these segments to avoid extrusion and bulging outside. Another thing that it is not applicable to patients with autoimmune diseases or immune deficiency like rheumatoid arthritis and AIDS, so we cannot apply them. That's why now the new area and the new trend of the use of the allogenic grafts take special importance to overcome these limitations and restrictions. Now we come to the second natural tissue additive procedure, which is known as the CTAK. The CTAK stands for corneal tissue addition keratoplasty. And although the name is keratoplasty, but really it is not a keratoplasty because we are not replacing any tissue from the cornea. However, we are adding tissue inside the cornea without removing any tissue from the cornea. So this CTAK is a novel surgical technique, new surgical technique that improves the corneal curvature, and hence it will improve the vision of the patients, especially in advanced cases with the keratoconus and the cases in which there is severe thinning of the cornea that no other techniques that improve the topography and the shape of the cornea can be contemplated, like the intracorneal rings. So this is an alternative procedure for intracorneal rings, and many studies done and shows significant improvement in the shape and the curvature of the cornea after the use of these tissues. These tissues are preserved tissue that can be used or stored for a long time, and it is devoid of any cellular material and is sterilized by gamma irradiation, and all the cells is removed from this tissue so that there is no any risk for rejection, and it is just pure natural collagen fibers which is preserved and is implanted in similar way like the intracorneal rings, and it is usually obtained from the tissue bank by ordering them. So let's dive deeply and see what's about the CTAK. Another type of tissue inlay used in the management of keratoconus is the what's known as the CTAK, which stands for customized tissue addition for keratoconus. It is the same principle as the CAIRS, but here the tissue is not a natural corneal tissue, but it is a frozen lenticule devoid of any cellular material and is irradiated by gamma irradiation, so that it is customized by femtosecond to match the topography of the cornea. And since it is devoid of any cells and gamma irradiated, so there is no risk of rejection for this lenticule, which is implanted inside the pocket, lamellar pocket within the cornea, so that it will act to flatten the steeper parts of the cornea, as well as add support to the cornea and increase the thickness of the cornea. And it is integratable, that it will integrate with the tissue of the cornea so that there will be no space or any interface between the donor tissue and the recipient tissue. So it is a promising procedure recently invented. And in the next slide or video, I show you quickly how the tissue is prepared and implanted. This is the lenticule. As you can see, it is customized in the company by CorneaGen and is gamma irradiated, as I said. And the customization is made based on the topography that you send to the company, so that they will customize a lenticule for you that is customized to that patients. Here, the same bucket is implanted inside the cornea based on the customization made by the company, and the same technique as you are implanting the intacs or the Ferrara rings, but here the tissue is a little bit more rigid because it is gamma irradiated and get implanted exact way as in intacs or Ferrara rings. So this is what's known as the CTAK. This is another procedure that's used to enhance the topography of the cornea. This slide shows you a picture of the patient before surgery and after surgery. You can see this is the contour of the light. As you can see, the bulging of the central part of the cornea. And this is after the implantation. You can see how regular the contour of the light. This is after 6 months. And this is the topography before surgery. And this is after 6 months. And this is the difference maps where you can see significant flattening in the center of the part as compared to the initial one. This is just in brief what's the role of CTAKs in improving the contour and the refraction of patient with keratoconus. The idea that this mode of surgery is affordable to those people who has contraindication and limits for other procedures. For example, if you have very thin cornea, you cannot do cross-linking. So you can increase the thickness of the cornea by this procedure and then do cross-linking. Also, if you have very steep cornea with very high K readings that you cannot do intacs or cornea rings. So by this procedure, you can flatten the cornea, and at that time you can do another procedure. Now in this slide, I will show a brief video the difference between CAIRS and the CTAK. As we said, the CAIRS stands for cornea allogenic intracorneal ring segments, and the advantage of CAIRS that is can be done by the use of traditional trephinations, that the same as we do in the synthetic segments, and also can be done by femtoseconds. This is the tissue which comes from the tissue bank. As you can see here, it comes dried and stained. And since it is dried, it will be a little bit more rigid. So it is easily to be introduced within the tunnel, similar to the synthetic segments. And the size and the length of this segment is determined by the tissue bank based on particular nomograms. So the procedure is very simple and can be done with use of local anesthesia. And this is the CTAK, which stands for the customized tissue inlay for keratoconus, and this is the segments which came from the tissue bank after removing all the epithelium and also all the keratocytes within the stroma by using the gamma irradiation. As you can see here, that the tissue came edematous, sleepy, and the introduction of this segment within the intrastromal tunnel is a little bit challenging. And the tunnel is made only by the femtoseconds. So this is one disadvantage, that It is not available in the places where technically femtosecond is not available, so it is not easy. So you need a special instrument to introduce it within the lamellar dissection made by the femtoseconds. And care should be taken not to traumatize the tissue. And similarly, the length and the thickness is based on the nomogram made by the tissue bank, based on the topography. You send the topography to the tissue bank, and they accordingly will customize this segment for you, so that it will deal with the steepening and flattening areas of the cornea. And you need to use this spreader to spread the tissue within the lamellar dissection, so that there is no crowding or compression of the segment within the corneal tissue. So this is briefly how the procedure is done for the CTAK, and now you notice the difference between CTAK and the CAIRS. بهذا القدر نصل إلى نهاية هذه المحاضرة، والتي كانت بخصوص الانترا كورنيال رينج سيجمنتس. كنا قد ناقشنا في المحاضرات السابقة treatment modalities in keratoconus, spectacle correction, contact lenses and cross-linking and intracorneal ring segments. في الجزء القادم أو المحاضرة القادمة سنتناول refractive surgery, keratoconus, keratoplasty and approach to a keratoconus case. إلى ذلك الحين وحتى يتجدد بكم اللقاء، أتمنى لكم دوام الصحة والعافية، وإلى المحاضرة القادمة بإذن الله، والسلام عليكم ورحمة الله وبركاته.